Hi, good morning everybody. My name is Victoria Braid. I'm the online clinical education leader for Northern Europe, and today we're going to do the cardiac acquisition and injection parameters presentation. I would like to ask everybody to wait until the end of the presentation if they have any questions they'd like to ask me, just because you may find that a lot of your questions are probably answered as the presentation progresses. If you do have any questions, what I will do is put my email address up so that you can email me your questions directly. Also, what I would like, if there are any people that have got more than one person sitting watching the presentation, if you can let me know, just so that I can issue you with the attendance certificate that comes with the presentation. So this course is primarily the for radiographers, and it's going to be about 30 minutes long. Okay, so the purpose of the course is to understand the effect of image contrast and contrast media on the quality of images and the dose. So by the end of the presentation, you should be able to appreciate the scanning parameters that affect contrast, appreciate the parameters that contribute to contrast and image quality, appreciate contrast protocols and parameters, and the difference in different acquisition techniques such as Miroi and Smart Prep. So this is how the presentation will progress. We'll look at acquisition parameters, contrast management, Smart Prep, and also Miroi timing bolus. So exam parameters that affect image quality and contrast are your KV and MA. So if we are scanning a person because we're more interested in the vessels, then in these examinations the Angio CTs are high contrast structures, so therefore we need different parameters, so different algorithms for this. So if our goal is exclusively vascular structures, we can be quite flexible in the amount of noise that we want in the examination. If we're not specifically looking for the soft tissue structures, basically what we can do is have a lower dose image, because the contrast we're going to see is going to be from the contrast we're injecting, and therefore we'll be able to see the actual vessel with a far lower dose. Obviously, if you're also wanting to look at the soft tissue structures, we're not going to be able to make that compromise, because we need the increased dose to be able to get the good image quality through the soft tissue structures. So we can see here, if we lower the energy, if we lower the X-ray energy, we actually increase the contrast within the image. Okay, but if we lower the energy too much, we increase the amount of noise in the image. So this is why we have a trade-off with our examinations. But again, if we're specifically looking at vascular structures rather than livers or kidneys, we can afford to compromise on the amount of noise that we see within the image. So the speed of the table. So what is really important when we're imaging patients to look at the vascular structure is adapting the speed of the table to incorporate the physiology of the area that we're interested in seeing. So if we're looking at a peripheral runoff, we couldn't use the same table speed for that as we would the carotids. We need to have a slightly slower table speed for the runoff because if we have too fast, we're going to get to the toes before the contrast. So that would not be useful for the examination. On the same score for carotids, we need a very quick tube rotation and table speed because the way that the contrast moves around the carotids and into the circle of Willis is really quite quick. The other tool that we have is pitch booster. So we can see here without the pitch booster, we've got quite a fast table speed. We can see quite a lot of beam hardening off the ribs, okay, and this can lead to the degradation of image quality. Whereas with pitch booster, what this does is it allows us to have a fast table speed. So obviously, because the table's moving very quickly, we're going to be averaging out the Hounsfield units to be able to compensate for the speed of the table. But it helps to reduce the amount of beam hardening artifact that is seen. So reconstruction. So just because we can acquire 0.625mm slices, it's not always the best way of achieving the images that you need. As we can see here, if we're looking at an aorta, you're probably better acquiring in 1.25mm slices because you're going to get better signal to noise ratio, okay? And because it's a gross structure that you're looking at, you're not looking for very small vessels, you've no need necessarily to have the sub-millimetre slices. Whereas if we're acquiring image data for things like renals and your neurovessels and your cardiacs, you are going to need that sub-millimetre data because the structures you're looking at are far smaller. Okay. So, these are all different ways that we can increase the contrast in an image without actually using contrast media. So now we're going to actually look at the physical contrast itself rather than just contrast within the image by altering scan parameters. So we know as radiographers that to reach the optimum enhanced level, we need to have the back of our mind that the time that we have to acquire the data is limited because of the speed of blood flow. So therefore we need to ensure that the iodine delivery rate is adequate. Okay, so generally, if we're acquiring angios, we don't want to be any slower. Whilst this says 3 to 4 mils, really any slower than 4 mils per second. And this is so that we can have a nice tight bolus of contrast that we can track as it travels through the body. If we inject more slowly, what happens is that bolus becomes more dilute, so the contrast is never going to be very, very dense. So the higher volume leads to a higher peak, and that also leads to a longer duration of enhancement, whereas the high flow leads to a high peak but a short duration. So we have to think about what we're wanting to image, and if we need the contrast to be there for a long time, or if we need the peak to be far more dense. So we can see here different examples of needing contrast with a quick flow rate, so that we're just seeing the arterial blood supply. We're not wanting the venous blood. So higher strength leads to higher IDR if all other parameters are the same. So thin and distal vessels are more difficult to enhance, so they benefit from a higher strength contrast, which is why we tend to use contrast of a higher osmolarity in coronary angios, and very often in neuro work as well. So the saline chaser, okay, what this allows us to do is very often decrease the volume of the amount of contrast that we need to use, because it's followed by the saline, so it actually pushes the contrast along and makes it last for longer, which obviously in patients who have got renal impairment is beneficial. But also what it can do is decrease artifacts that are generated by contrast of high strength. So if we don't want to see any contrast in the vena cava or the right ventricle, particularly when we're imaging cardiac, because if we have contrast in the right ventricle, it's then very difficult to visualise the right coronary artery. So we can have a dual injection, and this is where we inject contrast, but we have one bolus that goes in at a high flow rate to reach optimal enhancement, and the second bolus is at a lower rate, and what that does is it maintains the enhancement and allows us to reduce the volume that we're actually giving to the patient. So we can see that by using a saline chaser, we can decrease line artifacts, increase the length of the enhancement, and reduce the volume that we have to give to the patient. So now we're going to look at Smart Prep. Okay, and this is a tool that we're probably all very familiar with. It allows us in real time to monitor the IV contrast enhancement in one particular section of anatomy. So if we're looking at the pulmonary arteries, we want to see the pulmonary trunk reach optimum enhancement before we then trigger the scan, because we know that once the contrast is in the pulmonary trunk, when we trigger the scan, by the time we start acquiring, the peripheral vessels will then have the contrast in them, so that we're going to get all of the pulmonary vessels enhanced. So this is what it looks like. Okay, we go into Smart Prep, and we have our monitor location. Okay, and that tells us where we are going to be acquiring our slice of our region of interest. The MA, so we generally use quite a low MA because we're not looking for pretty images. We just need to see, see the contrast. What is crucial though is if we are scanning and we have a patient who's got a large body habitus, we need to make sure that whilst we don't need a very beautifully a very beautiful image with no noise, we don't want too much noise, okay, because we need to know that what we're seeing is contrast and not just basically the noise from the low dose. We have a monitoring delay, and the monitoring delay is dependent on what area of anatomy we're wanting to see. So if we're scanning carotids, we're going to have a very short delay here, because from injecting a contrast and seeing our first slice with contrast in it is not going to be 10 seconds. The contrast will have disappeared by this point. We're probably looking at maybe 2 or 3 seconds. And then we have our monitoring interscan delay, and this is every time we have a slice to show us where the contrast is, we're going to wait up to a maximum of 3 seconds and a minimum of 1 second. And the enhancement threshold, we can tell the system how many Hounsfield units we want to see, so that we know that the contrast in that area has reached peak enhancement. This is more important now we have dynamic transition, which basically is the tool that allows the system to auto-trigger the scan. So it will start scanning once we reach whatever the enhancement threshold is. And our diagnostic delay is how many seconds from us seeing contrast where we want the contrast to be, clicking start scan, it's going to take to start acquiring the data. This now with the newer systems is significantly decreased, so it's around 3 seconds. So if we are looking at our carotids, we want to start at the arch of the aorta, which is the origins of the carotids. If we're imaging a circle of Willis, we actually want to be in the carotids, because if we start acquiring our data down at the arch of the aorta, by the time we get the tables moved and we're up to the circle of Willis, we're going to be in more of a venous phase. So if we're looking at the for a pulmonary emboli, we want to be at the carina, and this is where our pulmonary trunk is, and it's the same level for if we're acquiring cardiac data. And if we're looking at scanning the whole aorta, we want to be in the abdomen. So we have 40 monitoring scans. If we don't see contrast after all 40 monitoring scans have run, then the system will pause. This is why it's important to have an appropriate scan delay, because it's pointless having, if you've got a very elderly patient with poor cardiac output, it's pointless acquiring scans as soon as you start injecting contrast, because potentially you may run out of monitoring scans before you actually see the contrast peak. Okay. So the only parameter that can be altered in Smart Prep is actually MA. Your KV matrix and algorithm are all applied depending on what you're scanning. So whatever is in the main body of your protocol is going to be what it populates the Smart Prep with. So KV, the matrix and the algorithm. So MIROI. This is a multiple image region of interest, and it allows you to generate a graph that's to represent density changes in a single area over a period of time. Okay. Now this particular method is actually a lot more sensitive and specific to patients. Okay. So we have multiple images, and it works in the same principle as your Smart Prep. So it's doing lots of slices in the same place. And we're then going to put a region of interest in the area of anatomy we are interested in. And what that region of interest will do is look at all those images, and it will pick from the pixels within that region of interest where the contrast enhances to its peak. So it's exactly the same principle. We put if we were doing a CTPA, we put it in exactly the same place as we would a smart prep. Now, what we can notice here that's slightly different is not only can we alter our MA, we can also alter our KV. We can also alter the scan field of view. Okay, these are things we can't adjust on our smart prep. But what you need to be mindful of, as we've discussed at the beginning of the presentation, is if we lower the KV to reduce dose to the patient, if we reduce KV, we increase contrast. So we're actually going to see contrast be more bright because it's got a lower energy, so it attenuates slightly differently. So what you do need to do is whatever KV you want to acquire your main scanning, you must use for your timing bolus, so that you know that your peak enhancement is the same. Okay, so we would take all of our slices and we would then put our region of interest in the area of anatomy we're interested in. And we can then go on to mirror analysis and click to generate a graph. And we count each of these little points, and each one of these points is 2 seconds. So it takes 14 seconds to reach peak enhancement. What we want to do is put a prep delay on, as we would with our smart prep, because we don't want lots of non-contrast images, because we want to reduce dose to the patient. So whatever your delay is, in this instance 5 seconds, you would need to add that 5 seconds onto your peak. So that will give you a total of 19 seconds, okay? And then what you would do is you would go into your next series, which will be your main protocol. And we've not got it, but where it says scan delay, okay, you would type in 19 seconds, and from there on it will just work as you would with a specific time delay with your protocols. So you would start the scan and the contrast at the same time, and after 19 seconds your patient you'd start to acquire the data. So we can see here that using this particular technique we can alter multiple parameters, including KV, although whatever KV we use for our timing, for our mirror, we need to make sure we use the same one in our main acquisition. So we can see that the scanning parameters affect contrast. So by altering KV, MA, we can increase or decrease the amount of contrast within the image. We can look at the parameters that affect contrast and image quality. So the lower the KV and MA, the higher the noise within the image, which actually affects the contrast because you see a lot more noise within the image. And we've got different ways of acquiring data using contrast. So Miroi is more specific for patients, perhaps if you're doing coronary angios or a circle of Willis, because you can make sure that the contrast hits the area of anatomy that is particular to that patient. There's no delay with start scan and the data acquiring, whereas you've got really a minimum of around 3.5 seconds with smart prep. So when you see contrast and you click go or start scan, you've got then an additional 3 seconds before you start getting that data, so the contrast is going to be a little more translucent. Okay, so that is the end of the presentation. I will put my email address into the group chat, and you can then email me with any questions that you may have. Okay? So I hope that this may have provided you with some useful information. And if you have any questions, please don't hesitate in emailing me. Also, if anybody wants access to GE Cares, please feel free to email me and I will give you the information on how to sign up to GE Cares. Thank you very much.